Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak to Dr. Jay Varma, the Senior Advisor for Public Health for the Mayor of New York City. Our topic is the city's ambitious effort at contact tracing. Let's listen. Dr. Varma, thank you so much for joining me. Take me back to when the New York City contact tracing program started.
Yeah, so this had been a program that we had really wanted to get up and running as quickly as possible. We knew that the only way that we could get to a level of New York City where we could return people to some semblance of normalcy, we're opening businesses and schools, was if we had a contact tracing program that accompanied the standard social distancing measures. So we officially launched on June 1st, which was the result of many, many weeks of planning, staffing, IT improvements, and capacity building. And at the time that we started, we were around 600 confirmed cases every day, which in some ways was a bit of good news because we had actually started planning in April on the assumption that we may be somewhere at the level still of 1,000 to 2,000 confirmed cases every day.
So for this program, what's the goal for how it's supposed to work?
Yeah, the goal is that, contact tracing is just part of a continuum. When we think about COVID, we think about three main tools. We think about things that individuals can do themselves, wearing a mask, maintaining physical distance, observing good hygiene. We think about things that government can do in partnership with people, which is a continuing of testing, case investigation and isolation, contact tracing and quarantine. And then the third, of course, are things that government has to do, which is close non-essential businesses, limits on gatherings. The third is obviously the one that we want to avoid as much as possible. So our vision was to have a contact tracing system that first involves the most widespread expansion of testing that you could possibly have in any city in the United States. And that's a level that we've basically achieved where we're getting to around 50 to 60,000 PCR tests done per day, levels that you only see really in Singapore and a few other places. And that is immediately linked to a program for case investigation and contact tracing. And then, of course, all of the support mechanisms that are needed to help people stay in isolation for anywhere from 10 to 14 days.
So if I'm in New York and I test positive, what happens?
So if you're in New York City and you test positive, the good news is that if you go to one of the sites that is currently run and operated by the city, there are over 40 to 50 sites that are specifically operated by the city, you'll have a PCR test performed. We currently use what's called an anterior nares swab, which is a short swab, kind of like a Q-tip, so it's a little more comfortable. And your test results, again, if you come to a city-run test site, are going to come back to you. The vast majority come back in 24 hours, and almost 100% come back in 48 hours. You yourself will get notified of your positive result from the laboratory. And then, ideally that same day but up to 24 hours, you'll get a phone call from one of our contact tracers. And those contact tracers are going to basically ask you about the following things. The first is they're going to find out a little bit about who you are and about your medical history. The second is they're going to find out about places you might have been in which you might have gotten infected. The third is they're going to find out about who you might have infected yourself, that is your close contacts. And the fourth is they're going to find out about support services that you need. We supply things like food delivery, pharmacy delivery, dog walking, medication refills, a whole bunch of support mechanisms that we know people need.
Now, are you able to do this for people who don't go to one of the New York City sites as well?
Yeah, and so I think the more important point to note here is that our city sites are just an adjunct to all of the testing resources available in the city. All test results are required by law to be reported electronically to the New York City Health Department, and that's a system that not just for COVID but has existed for all infectious diseases. So it's a very complete system, and so we're quite confident we get all the results, and then all the results are acted on.
Now, how many people does it take to run a program that offers this kind of support for everyone in New York that tests positive?
Yeah, this is a massive initiative. And I can tell you, I'm here in the first week in April. I was previously working in Africa and helping to set up the response continent-wide in Africa. And for personal and patriotic reasons, and at the request of the mayor, came back here in early April. And this was really one of the big initiatives that I launched. And the reason I give that background is that when I started explaining this to the policymakers, the people that write the checks, it was hard for people to wrap their head around the notion that we were going to have to bring on board, thousands of new people to make sure this program worked and to convince people that investment was necessary. So right now we have about 4,000 people who work specifically on contact tracing. They work remotely using an integrated IT system that incorporates phone dialing and remote queues, somewhat similar to the way a call center might work. And they have the capacity to do at least 2,000 confirmed cases a day and possibly more if necessary.
Now, some of the people who are testing positive may not speak English. They may have mistrust of the healthcare system. How do you build a contact tracing effort that is going to overcome those barriers?
Yeah, we have a lot of experience in New York City with contact tracing kind of at a smaller scale. I mean, we probably, manage as many cases of COVID in a week and do contact tracing for them as we do for all infectious diseases in a year under normal circumstances. So this is definitely many orders of magnitude greater of a requirement, a program. But what isn't different is the fact that this only works if the people who are doing the contact tracing are actually from the communities in which the cases are occurring. So we made a very intentional effort at the outset to recruit people from every neighborhood in New York City. So they not only, look like and are neighbors with the people who are getting sick, but they speak the same languages as well. And that has taken effort, but because it was so intentional, it's been an incredibly important success. We've also partnered with a number of community-based organizations who can also provide support services. So there's also adjuncts in the local community as well.
How do you know whether this is working?
So this is a really challenging question. So I would say, first of all, we were one of the first jurisdictions to actually make our contact tracing performance metrics publicly available in the second and third week of June. Yeah, so about 2 to 3 weeks after we started, we put all of our data up on a website and made it publicly available. And what I mean by that is really kind of a cascade. So like if you have 100 cases are reported, how many pick up the phone, how many actually complete the interview, and how many actually report completing the 10 days of isolation. And then the same thing, of course, for the contacts. And the reality is our numbers were not that great at the beginning. This is an incredibly challenging type of disease to manage because unlike diseases like tuberculosis or HIV, you don't really actually have anything to offer people. With those diseases, when you do contact tracing, we have medications that can basically either suppress the virus for HIV or cure it for TB. Here, we're really only offering people the possibility to benefit them from infecting other people. So our performance metrics have grown over time. And I do think one good aspect of us publishing this data at the beginning has been that more and more jurisdictions are showing this. Now, whether it's actually working or not is a challenge because really what we only have is we have data from modeling estimates. And our modeling estimates show that when combined with our current adherence to kind of mask wearing and physical distancing and limits on gatherings, this is an important way that we can both keep numbers down. And if there are increases like there are right now, we can prevent them from accelerating rapidly.
Now, how many new cases do you have every day roughly in New York City now?
So right now we have around 500 to 550. We reached our lowest point during August and early September, when we had about 200 to 220 cases every day. And at that time, we were really trying to figure out ways that we could drive transmission to zero. Our real goal is to reach a level where you're somewhere on the order of maybe one case per 100,000 every day, which in New York would be about 80 to 85 cases. Unfortunately, we had a number of areas of the city that were not really being very adherent to mask wearing and to gathering restrictions. And those localized, clusters eventually spread and caused problems throughout the rest of the city, as well as the problems that we know about. As the weather gets colder and people get fatigued, their willingness and ability to adhere to guidelines is less.
Sure. So of those, say, 500 cases, how many of them are people that you had already reached who are contacts of known cases?
And this is one area there where I have to say that we have not performed nearly as well as I had hoped we would have. In the ideal world, you have control over an epidemic when every new case that's occurring is actually somebody who was already known to you as an exposed person. And therefore, all chains of transmission are known and under control. The reality is, for us, it's probably somewhere on the range of about 20 to 25%. So the majority of cases, and that's been pretty constant, even in the days when we had lower levels of transmission. We had a fair number of cases, even at our lowest standpoint, that were due to importation. So about 20% of our cases were imported. And then about 10 or 15% of the cases, again, during our lowest time period, were due to transmission in congregate settings or healthcare facilities. So those are things we had a lot less control of. But even in those days, we never really got to the level that we would have liked to, where we'd have, say, 80 or 90% of cases that were known to us.
Well, still 20 to 25% is not a negligible number of cases that you are identifying among the people who were in quarantine because of contact tracing.
Yeah, and that's one of the reasons we think pretty strongly that we are having an impact. I think it's somewhere on the order of 10 or 11,000 contacts have converted to being cases, and those are people while they were under monitoring for us. And so to us, those are situations in which, if you assume that the reproductive number on average is about 2, we know there's variations in the way that's dispersed, but if you assume a number of 2, then you're talking about 20,000 or more potential cases that have been averted because these people were known to us and being monitored. And being provided with resources to make sure that they stay in quarantine or isolation.
So as you look ahead with cases just spiraling out of control in many parts of the country, New York has, one of the best, if not the best, systems for contact tracing in place to try to prevent that from happening. What keeps you up at night?
I have to say that I am in a constant state of anxiety all the time. I think what really keeps us up at night is the fact that we don't really know what the inflection point is for exponential growth. Right now, we were optimistic in late August, early September that we'd be able to drive cases potentially even down to double digits or less. Now we're just hoping to keep a lid on things. And that's because we know that we are not able to control our borders in the same ways other people is. So there's always going to be the introduction of cases from the surrounding area or from people flying in elsewhere. So that's one thing that always worries me. And we've tried to do a lot, and we've put a lot of rules in place. But again, we're not an island. Number 2, I think what really worries me is the sequential holidays. We saw a fairly, pronounced and notifiable increase due to the Jewish high holidays, because we know a lot of people are doing gatherings. Those are important holidays for members of those communities. Now we have Halloween. Next we have Thanksgiving. Next we have the Christmas and New Year's holidays. So what really worries me right now is our ability to get people to adhere to mask wearing and distancing and limits on gatherings during this holiday season.
We were talking about the 500 cases you have a day. At what point does it become hard to contact trace every case, given how many people that you have hired?
Yeah, interestingly enough, our performance metrics have gotten better and better every week, even though our case numbers have been increasing over the past.
And let me break in for a second just to say what some of those numbers are. I'm looking at your most recent report. over 90% of all cases reached. Is that right? And over 75% of all cases with a complete intake.
Yeah,
and
that's
over
correct.
2/3 of all contacts with a complete intake. So you're really reaching by far the vast majority of people in New York who are getting infected right now.
Yeah, no, it's getting better, and I think that's because we've gotten to we really scaled this program fast, but quality takes a while to develop, and we know that from our HIV and TB and STD program. People don't become skilled at doing this. And so it's only really been, even though our case numbers have been going up for the past 4 to 6 weeks, it's probably the most stable period that we've had where we haven't had to bring on new staff, train people in new roles. And so as a result, I think people are getting better at it. So we feel pretty confident that even if our case numbers, went up fourfold to around 2,000, that we would still be able to continue to do contact tracing. I mean, I think the much larger question becomes, what is the incremental value of at that point? I think it always continues to have value, but you start to again think about those three tools that you have: the individual measures, the contact tracing, and then the third is the government restrictions. And I think you start to move into a need potentially to have those restrictions, but of course we want to put those off as much as possible.
Got it. Well, I certainly wish you the best. I really appreciate the magnitude of the accomplishment that you have standing up this massive public health response effort. And I hope things stay quiet or get quieter on the COVID front in New York City.
Great. Thank you very much for having me.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.